Welcome. My name is Azza. I'm Bariatric Program Coordinator at the Reston Hospital. And I am excited for you that you decided to take a journey towards weight loss with us. We have a team of dedicated bariatric professionals that are trained and dedicated and know how to recognize your unique needs before, during, and after surgery. We offer online preoperative class during which you can learn how to prepare for surgery and what to expect during your hospital stay. We also offer medically supervised fitness program as well as the monthly support group for everybody before and after surgery. All the information is available on our website, and you can also call me at my phone 703-689-9328 with any questions regarding the bariatric program. Again, thank you for choosing Reston Hospital. We are all excited to have you here and to meet you. Thank you.
Welcome again to Reston Hospital Center webinar. My name is Osvaldo Anes, and I am one of the surgeons here at Reston Hospital Center. We're going to try to put together a presentation that hopefully will be informative, short and easy for you. That is our agenda. Welcome again. I'm going to talk a little bit about myself and definition of different terminology that we use on daily basis. And then obesity and the problems it causes, normal anatomy, and then how we change that anatomy to make it possible to offer you surgical options that make you lose weight. And that is me again. I've been in practice for over 32 years. I have done about, or perhaps more than 5,000 surgical bariatric procedures. I went to medical school to the University of La Plata, Argentina. I did my residency in surgery at the Reston Hospital Center, where I was a chief resident. I am board certified, and I am a member of a fellow of the American College of Surgeons, as well as the International College of Surgeons. And I am also a member of the American Society for Metabolic and Bariatric Surgery. These are the definitions we're going to go over, so we are in the same page when we talk about the different topics and measures that we need to take to qualify you, to see if you qualify for bariatric surgery or not. Ideal body weight, body mass index, obesity, morbid obesity, comorbidities, and indication for surgery. First of all, we're going to talk about the ideal body weight tables. They are very popular, used by most surgeons and people in general, but as you can see, it will give you just your ideal body weight. It's not a measure of your index of overweight. The way you calculate your ideal weight is you plot, that is for female and male, you plot your height on the left side, and then you choose a frame that you think you fall into. I recommend that you use the large frame because these weights are really small. And then you calculate, if you were like 5'7", your ideal weight will be 143 to 163 if you were a female. And if you were a man, your ideal weight will be 149 to 168. Just your ideal weight, but it has nothing that expresses your real weight. That's why we go to the next table, which is called the body mass index. Complex formulas are used to calculate this body mass index. I don't recommend that you deal with that, just use the tables. You plot on your left side, same as the other table, your height, your weight on the top transverse, and where they meet is your body mass index. Body mass index between 18 to 25 is normal. Between 25 to 30 is overweight. Between 30 to 40 is obese. Between above 40 is extreme obesity or morbid obesity. So now we have an expression of your own weight, not just an ideal weight for anybody. The body mass index in red are the ones that qualify patients for surgery. And here, again, we see normal, overweight, obese, and what you see in red is what qualifies patient for surgery. Severe obesity is a new terminology for patients that are now having a BMI of 35 to 40 and have one or more comorbid conditions. And in reality are three: hypertension, diabetes, and sleep apnea. Those three are the ones that insurance consider to approve the patient with that weight. Morbid obesity, BMI of 40 and above, qualifies patients for surgery just based on the BMI. And of course, over 50 as well. What is obesity? We now know it's a disease of excess fat storage, and we'll see why it's the disease. It is multifactorial. It has a very heavy genetic component that allows the environment to control our eating habits. So it's not a simple issue. It is more of a complex, multifactorial disease. We all know it's costly, it never goes away, it gets worse, and it causes a lot of issues that we'll see in a little bit, and it can be life-threatening. Morbid obesity, it is the most extreme form of obesity, as we said before, body mass index of 40, or could be 35, with hypertension, diabetes, and sleep apnea. Okay? It could be also expressed as a 200% of the ideal body weight value or 100 pounds over ideal weight. And these are all the diseases and maladies that obesity can cause. We know about these three. I put them in red because those are the ones that the insurance recognize as indication for surgery. But then you have respiratory disorders such as asthma, obesity hypoventilation syndrome, pulmonary hypertension, congestive heart failure, and so on and so forth. Hyperlipidemias means high cholesterol and triglyceride that eventually causes heart disease, strokes, etc. And as you see, the diseases caused by obesity are a good number of them. Why surgery? Only surgery has proven effective over the long term for most patients with clinically severe obesity. Is a conclusion from the NIH Consensus Conference statement in 1991. What are the indications for surgery? By now you probably know, either a body mass index of 40 or could be 39 to 40 with sleep apnea, diabetes, or uncontrolled hypertension. And of course, you have to have tried conservative diets before and failed, and have the condition for at least 5 years and be at least 15 years of age. Now we're going to move on to the anatomy. We're going to go over the normal digestive system first, and then what do we do to it to change it so it works to make you lose weight. Here we go. I know you all know about this, but it's always good to refresh it. This is your esophagus. It goes into your stomach. The stomach has a capacity of 1,000 cc's or 1 liter, and it can stretch if you are very hungry a little bit more. Then it goes into the small intestine. The first portion of the small intestine is called the duodenum. The duodenum has a special function. It's where most of the calcium, iron, vitamins, and micronutrients gets absorbed. So any operation that bypasses the duodenum will require that you supplement yourself with these elements for life. Now, Following the duodenum, we have the upper part of the small intestine, which is called the jejunum. It's about 200 centimeters or 2 meters. And the distal end is the ileum, which is 300 centimeters. So in total, we have 5 meters of small intestine that absorb everything we eat. So it could be a little shorter, as well as the stomach could be a little smaller to be able to lose weight with a more friendly anatomy. Restrictive procedures are those that only limit the amount of food you can eat at any given time, made stomach smaller. The band was popular some years ago, now it's going away. The sleeve gastrectomy is coming strong. Perhaps it's a procedure more frequently than in the country, perhaps because the number of surgeons doing it is much more larger than the surgeon that can do the gastric bypass. And this is the band, just for completion. Pure restriction, progressive slow compression of the outlet by inflating the balloon that is inside, prevents you from being hungry. It's the safest one. There is no stapling. It is reversible. You just remove the band. And very low chance of malnutrition. But the problem is that at 3 years, the weight loss settles in about 30%, if. That's why perhaps is the reason why it's going away. Potential complications of it, as simple as it seems, there are, from migration of the band, slippage, dilatation, etc. The sleeve resection, purely restrictive, it makes the stomach smaller, but somewhat larger than the band and the bypass. It makes about 20 to 25% the size of the original stomach, and the rest of the stomach is removed. Hence, is irreversible. Ghrelin is decreased because it seems that ghrelin, the hormone that increase your appetite, is made in this part of the stomach. So now that it's gone, the appetite is gone to a certain degree. Expect an average weight loss of about 50% at 3 years and 50 to 60% at 5 years. Potential complications, reflux. Let me go back here. This anatomy here creates a valve that is an anti-reflux mechanism when you eat. Doesn't allow the food to come back up. Now, when you remove that piece of the stomach, then you can have reflux more frequently. Leaks, bleeding, strictures, they are all on the low side, comparable to any other surgery. Now let's move on to the combination procedure. The most popular is the Roux-en-Y gastric bypass. It's been done longer than any other procedure, produces better weight loss and more consistent long term. Surgical risk, similar, higher resolution of diabetes, and best control actually cures acid reflux. Ooh. And this is a gastric bypass. Make the stomach smaller, restriction, causes food to bypass the stomach and part of the small intestine, decreasing absorption of food, bypasses all this, and causes a damping syndrome physiology for behavior modification. Damping syndrome is if you eat or drink too fast, you will distend the small intestine, and it causes pain, nausea, vomiting, diarrhea, tachycardia. That's a damping syndrome. So it works 3 ways. This is how I do it myself. I've done it for so many years. A small incision takes about 35 to 45 minutes to complete the full gastric bypass. Hospital stay 1 to 3 days. And the way I do it is reversible because I staple in continuity, as you will see later. This 5, 6 incisions as for the robotic or the laparoscopic gastric bypass. Takes 1.5 to 3 hours to do, same hospital stay, and it could be very hard to reverse. Because when you do a laparoscopic or robotic, you need to transect the pouch of the stomach. When you do it through my approach, the mini incision, you just staple in continuity. So should the need for reversal come, you just need, it's easier to put together the pouch of the stomach. Potential complications, as you can see, they are all on the low side. They are the same as every other operation. Gallstone is a little higher from losing weight fast, not so much from the operation. And that's about the end of my presentation in the 20 minutes that I had. Questions are welcome at this address. And thank you for attending our webinar. We hope that the information presented helps you understand the modifications that are made to the normal anatomy in order to help you obtain a more durable weight loss. But any surgery that you choose will require your full commitment with the postoperative program, support groups, and exercise, as well as nutritional counseling. Surgery is just a tool.
Hi, my name is Kareem Trad. I'm a general surgeon here in Reston, at Reston Hospital. I'd like to take a few minutes to tell you about the bariatric surgery program that we participate in. We are a full-fledged bariatric surgery practice. We offer the sleeve gastrectomy primarily. We'll talk about this in a minute. But I'd also like to mention our team members because bariatric surgery is always a team effort. Paul Marino, who's a PA, has been doing this for a long time, extremely experienced, and Allison Barnett is our bariatric nurse. And I can tell you that patients love her because she does respond to her emails and she's extremely present in the entire process. We have a support group that takes place on a monthly basis, online support, a buddy system as well, and that sort of thing. So what do we do? Our practice does bariatric surgery, but not exclusively. We do take care of foregut surgery, which is upper GI problems, and such as hiatal hernia and reflux, and that does prepare us to take care of problems that may arise in this area as well. The patients, if you come to our office, it means a few things. It means that you probably have tried everything to shed the weight. The medications, the weight loss programs, the exercise programs. And your BMI or body mass index at this point is over 35. In that category of patients, your odds of successfully losing weight in a sustained fashion is probably less than 5%. That's what the studies show. If you come to our office, you probably also have all the medical problems or some of the medical problems that go with morbid obesity, such as hypertension, hypercholesterolemia, joint pain, sleep apnea, and other problems as such. So to be considered for surgery, it's obviously not for everybody. We take this very seriously. It is the option of last resort. But it's one that is extremely successful when done properly on the right patients and in a safe manner. What are the goals of undergoing a surgery like that? Really, there are multiple goals. The first one is improving your quality of life. Because it is difficult to be in that BMI range for a number of reasons that I don't have to tell you. Your health also is at risk because you've developed comorbidities, or those are the diseases that go hand in hand with this kind of excess weight. And if you treat that problem, you will likely take care of the other problems. And as a result, you will you can enjoy a longer life expectancy. This has been shown repeatedly. So those are the goals. If you're going to look better and thinner and feel good in your body, that's a plus, no question about it. But we're not about cosmetic surgery. This is serious surgery. This is to improve your health and to keep you safe and to live long, so that your loved ones can benefit from your presence. The procedure that I favor is called a laparoscopic sleeve gastrectomy. There's a slide here that has some of the highlights. It's done laparoscopically, which means we're going to use very small incisions. And what we're planning on doing during this operation is to remove a major portion of the stomach and just leave behind a sleeve-shaped tube, which is now your residual, the stomach. Why does that work? It works for several reasons. Because it restricts the amount of food that you can take. But importantly, by removing the stomach, what we're doing is eliminating the production of ghrelin. Ghrelin has been shown as being the hunger hormone. So unlike other operations, you actually see patients telling you after surgery that they're just not attracted to food anymore. And I know that's hard to imagine, but that is the truth, and there's a scientific explanation behind it. It's also my favorite operation because it's been shown that there are less hospital readmissions than with other options, such as the gastric bypass, and also less complications. So for me, it's the go-to procedure. Now, it is not reversible, and we know that, so that's why the decision has to be taken very seriously. What is it going to look like for you? You're going to be admitted to the hospital. The operation will take less than 2 hours. You're going to be under general anesthesia, so your primary care physician will have to clear you for surgery, make sure you're not at risk to be under general anesthesia. By then, you would have had the teaching. The hospital here runs an excellent program where patients are prepared before surgery and actually followed after surgery as well. You will get dietary instructions, and you would have had your psychological profiling as well. The surgery takes place, and you spend 1 night in general in the hospital. Occasionally, we keep patients 2 nights. The night after surgery, we do a special x-ray to make sure that you don't have any problems, that you didn't develop a leak or a stricture or something of the sort. And only then do we advance the diet. We allow you to drink. Basically, you're going to have to be prepared to be just on liquids for a couple of weeks, and then we will allow you to advance the diet. But we will teach you how to supplement your diet, not to get dehydrated, not to get vitamin deficiencies and things of the sort. So you will feel accompanied through the process from A to Z. After you go home, you're on your own, but not completely, because we're only a phone call away, an email away, and we understand that you need to have the support, and so you will never be on your own. We will see patients very frequently. We see them a week after surgery, then 2 weeks after that, and as often as it is required. It's been shown that patients who are seen frequently actually have a better weight loss result. And of course, our support group is there because then you can compare your experience, learn from others, and also let others benefit from your own experience. And it's a wonderful, wonderful way to do the journey along the success. What you can expect with this operation on average is to lose 65% of your excess weight. In other words, the odds of you, if you have 100 pounds of excess weight, on average you will lose 65 pounds. But that doesn't mean that you couldn't lose the entire 100 pounds. That's an average. But that is an exceptionally good type of result. And Other procedures like the lap band never really achieve that. Since I mentioned lap band, I want to mention something. We do have in our practice a large number of patients who have had the lap band in the past. And the lap band is used to be considered as a really good operation. That's no longer the case. Very, very few people actually undergo this as a choice operation. But it has worked for some patients. Importantly, they do need to be followed up. We do that. We take them on. Even if we didn't do the surgery, we're happy to advise them to adjust the bands. And in some cases where the band is no longer functional or it has created complications, we're totally able and willing to remove the band and maybe consider other options as an alternative if they still need an operation of the sort. I just want to say a word about complications because there is no surgery that isn't associated with complications. Fortunately, this is one of the safest operations under bariatric surgery. The stricture rate, which means the narrowing of the path that we have created, is extremely low. It's something in the range of 1% to 2%. The other major complication is one where there is a leak or the staple line separates, and therefore you have the potential for an abscess or an infection. And those are complications that thankfully can, most of the times, in the great majority of the time, be treated endoscopically, which means you don't need a repeat operation. It can all be handled with an endoscope. Obviously, we pride ourselves in having a very low complication rate, and when they do happen, because they will eventually happen to someone, we know how to handle them and keep patients safe. I just want to conclude by saying that the philosophy of our practice is the belief that the best way to care for patients is to care about the patient. And I think we do that very well. Patients aren't numbers. This is not a factory line. Everybody's looked at individually, and we take great care in bringing those patients who entrust their health to us safely on the other side after the surgery. And we will only do surgery when it's needed. We're very proud to be part of the bariatric program at Reston Hospital. It is a center of excellence. It has that designation, which is not easy to obtain. And we have a fantastic team, aside from the people I have mentioned, in the hospital that we're very proud to be part of. So if you ever make the choice or want to come and see us in the office, we'd be happy to talk to you some more about all of this. Thank you.
Thank you for tuning in. I am Dr. Fitzer, and I am going to tell you a little something about the gastric bypass. First, I should start by telling you a little bit about myself. I'm a bariatric surgeon. I am from Virginia, and that is where I grew up, and it's where I went to medical school, at Eastern Virginia Medical School. And if you don't know how medical school works, it's 4 years long. At some point in those 4 years, they expect that you are going to figure out, at least sort of generally, what kind of medicine you want to practice when you graduate. And the reason that you have to figure that out in medical school is you can't just sort of graduate from medical school and then go to work someplace as a doctor. Technically, you are a doctor the day you graduate, but before it's legal for you to actually take care of a patient, you have to get a medical license from a state. And before a state will give you that, you have to do some additional years of training in some more focused area of medicine. And those additional years of training are what is known as residency. And if you watch any medical TV, you already probably learned a little something about how residency works, because most medical TV shows tend to focus on residents. I personally used to watch ER religiously. That disappeared and sort of was replaced by Grey's Anatomy, which I never watched. And I used to watch Scrubs quite a bit. Actual residents revered Scrubs. But in any case, you get the idea. So I figured out in medical school I wanted to do some kind of a surgical subspecialty. And the starting point for that is a general surgery residency. That's 5 years long, and so I made arrangements to do one of those, which I started on a nice, bright, sunny July 1st in the year 2000 down in lovely Savannah, Georgia. And down there is where I got interested in weight loss surgery, which actually happened in 2003 when one of the very intelligent surgeon down there, far-sighted guy, former transplant surgeon, by the name of John Angstadt, started a weight loss surgery program. And helping him take care of those bariatric surgery patients, I figured out pretty quickly that when we were doing weight loss surgery for somebody, in the end, we would do a lot more net good for that individual with that weight loss operation than, from my point of view, you could do with just about any of the other kinds of surgery that I was being introduced to. And so I decided that's what I wanted to do, but by the time I figured that out, I was rounding the bend of my 4th year of residency, and I was self-aware enough to realize I was getting ready to graduate without enough hands-on training doing this surgery to perform it at really a high level afterwards. And I knew I needed more training. And so I did a little bit of investigation. I found out more training was available, actually, in the form of what's called a surgical fellowship. Surgical fellowships are additional years of training that you can sign up for if you haven't had enough after 5 years of general surgery. During the fellowship, you get training in some more focused area of surgery. And those fellowships, incidentally, are how most of the surgical specialists that you've heard of get created. For instance, if you know someone who had open heart surgery, God forbid, your father had quadruple bypass last fall, the cardiothoracic surgeon that did that, he's a guy who, like me, he would have started out by doing 5 years general surgery residency, but then he went on to do an additional 2 years of cardiothoracic surgery fellowship. Likewise, if you know someone who had plastic surgery, your Aunt Trudy had a facelift in the spring, the plastic surgeon that did that, he is a guy who, like me, did 5 years general surgery residency, but then he went on to do an additional 2 years of plastic surgery fellowship. Although these days there actually are some other pathways by which someone can become a plastic surgeon, but you get the idea. So I did some looking around, and I found out that there actually were weight loss surgery fellowships. And I made arrangements to start one of those, which I did on a nice, bright, sunny July 1st in 2005. I graduated a year later, June 30th, 2006. I took a few months off and then went into full-time weight loss surgery practice in a very busy practice in the frozen tundra of upstate New York, where I worked for 5 years and change before I figured out that it was too cold for Virginians and I wanted to come back to Virginia. I started snooping around about how exactly I was going to do that in sort of mid-2011, and I actually moved back down here February 2012. So I've been down here like 5 years and change now. And that brings us up to date. So the gastric bypass. If you want to understand how the gastric bypass, otherwise known as the Roux-en-Y, how that works, it basically works the same as all of the other restrictive operations, including the sleeve and the band. And if you want to understand how those operations work, you first need to understand, at least sort of generally, how normal anatomy works. And that is what we have with this first slide, normal anatomy. This is what you have today. Some of these things are certainly familiar to you. That is this nice lady's mouth. Mouth is connected by this thing, the esophagus, to the stomach, which is down here. Most people could pick the shape of the stomach out of a lineup if need be. The esophagus, incidentally, that's a muscular tube that has one job in life, and that job is to push the stuff that you decide to swallow from your mouth down to your stomach. So here's your stomach, right? The stomach, it turns out, is pretty big. You can read on the internet in various places that it's the size of a fist, but that, it turns out, is not accurate. The average adult human stomach, when it's full, it holds somewhere between about a quart and a quart and a half. And everybody knows what a quart of milk looks like, right? Everyone has seen one at the 7-Eleven or Wegmans or whatever, right? So you know what a quart is. It's about yay big, right? Much bigger than that fist, by the way. So if that's a quart, the average human stomach, slightly bigger than that, about that big, pretty big. So the average human being that has that average sized stomach, they usually find that they can fit a pretty substantial amount of food into it if they give it a try. right? Usually most people can fit at least something like most of a medium pizza into it, you know, maybe most of a large pizza, depending on who you are. In any case, when that individual puts that pizza into the stomach, for the stomach to accommodate that last little crust that brings it up to its full capacity, your stomach ends up having to stretch a little bit, like a balloon. Your stomach is sort of elastic. And so when your stomach stretches in that way, right, it develops a little bit of tension in its walls. Now, all human beings have some special nerves in the walls of their stomachs that have the job of detecting that tension or that stretch. And what those nerves do in reaction to it is they turn on a special nerve signal to your brain. Specifically, that nerve signal that a stretching stomach sends your brain, it goes to that part of your brain that has the job of feeling satisfaction from food. It is that nerve signal, right, that your stomach is sending to your brain, building up over time, which is what gives you that feeling of fullness that you're used to getting after you eat. In the case of that pizza I was talking about, it's the continuous action of that nerve signal from your stomach working on your brain over those 25 minutes or so that it's going to take you to finish that pizza. That is what gives you that feeling of extreme fullness that you usually get from a pizza, right? That makes you go, whew. You push the pizza box away. You promise everyone there that you're never going to have that much pizza at one sitting ever again. If nobody's paying attention, maybe you undo your top button under the table to make a little bit more room, and then perhaps go plop down on the couch for an hour. That feeling of extreme fullness that you get that comes from stretch of the stomach by the special action of that nerve, that's called the satiety reflex. And that satiety reflex is what all of the restrictive operations, including the gastric bypass, use to help you lose weight. So, to explain the gastric bypass, what we do for you with that operation is we make you a new stomach out of the top of the old one. And this little thing up here is it. That is your new stomach. And we call the new stomach the pouch. And the pouch is the key to the gastric bypass operation. It's the most important part. And by the way, the pouch is the key to all of the operations, right? Band, bypass, and sleeve. You get a pouch with all of them, and it really is the part responsible for the weight loss. Now, that little pouch that you get with a gastric bypass, it is obviously pretty small, right? It's a lot smaller than the old stomach out of which it was created there. It's just a little tiny corner of that old stomach. You're not going to fit a whole pizza anymore into that pouch after you get gastric bypass surgery. The pouch, in fact, would not even fit a whole piece of pizza. It's going to fit like 4 bites, right? Maybe. 3 or 4 bites. But when you put those 3 or 4 bites into that little pouch, the pouch fills up and it stretches, right? And it turns out that most of those special nerves that we human beings have in our stomach that have that job of detecting stomach stretch, those nerves are concentrated in the top of our stomach, in the piece out of which we make your pouch, right? So those nerves are still there. And now, after a bypass surgery, when those 3-4 bites of food come down, fill that pouch up and gently distend it, those special nerves are there to detect that. And from the perspective of those special nerves in your pouch, after bypass surgery, they have no way to perceive when the pouch is full and distended that the old stomach is no longer connected and that it has nothing to do with that filling they're experiencing. Right? Those nerves, they just sense a full stomach. And they do what they used to do when they sensed a full stomach. They turn on that full stomach signal to your brain. So about 20 minutes after you eat those couple of bites of pizza with your gastric bypass, your brain experiences that same old whole pizza feeling. You go, whew, you push the pizza box away, promise everyone in attendance that you're never going to have that much pizza at one sitting ever again. If nobody's paying attention, you undo your top button, possibly, and then you go plop down on the couch over there for an hour. And you were going to be sitting over there on that couch feeling for all the world like you just ate another whole pizza. Right? The feeling is identical to what you had before surgery after you ate a pizza. This time, though, if you get up and take the trouble to inspect the pizza box, you will see that this time it's not an empty pizza box. This time, there are just a couple bites missing out of one piece. So what you've done here with the bypass, if you stop and think about it, is you use that little pouch to trick your brain into thinking that you had this really large meal when what you actually had is a very tiny meal. And that's how it works. It's really not very complicated. You're using that pouch to trick your brain into thinking that you had much more food than you actually did, so that you just end up choosing to eat less, right? You're eating less as a matter of choice. The idea with the gastric bypass is to take advantage of this effect 3 times a day, every day, at breakfast, lunch, and dinner. At each of those meal times, what you want to do is put the right small amount of food into that pouch the right way. If you're good at it, if you're a skillful bariatric eater, you're going to go through your day feeling like every time it's time for you to sit down and eat, it's going to seem to you like you had a Thanksgiving dinner-sized portion, right? You'll get up from your meal going, oh, right? But if you're a skillful bariatric eater, the amount of food it's going to take you to generate that lifelike Thanksgiving dinner level of satisfaction, it's just a tiny amount of food. If you're a skillful bariatric eater, it's probably going to take you about 2/3, 3/4 of a cup of food, right? So, again, if you're a skillful bariatric eater, even though you're going all day long feeling Thanksgiving dinner stuffed, if you add up the amount of food it took you to make that happen, it's on the order of 2/3 of a cup of food per meal times 3 meals. That's on the order of 2 cups of food total per day. And as you can imagine, if you went all year long eating 2 cups of food per day, you would lose quite a bit of weight. And people do. It works quite well, which I'm sure has something to do with the fact we're talking about it some 50 years after they started doing it.
Hi, I'm Susan Smith. I'm the Clinical Nutrition Manager here at Reston Hospital Center. I just wanted to give you a little bit of an idea of what your diet will be like immediately after surgery and in the future while you're here at our facility. Your nutrition plan will basically have a couple of options immediately after your surgery, and one is a bariatric clear liquid diet, which means you get to have some clear liquids, and the progression to a bariatric pureed diet, which means you get to add some other foods to that too. Now, protein supplements might also be given during this time to make sure that you get that protein to maintain your strength and to heal properly, but it depends on your progression. What should you expect during your stay? Well, once your doctor has cleared you to start a diet, you will start on the bariatric clear liquid diet. That diet will give you the following types of items, which would be broth, diluted juice like apple or cranberry, and also sugar-free or diluted liquids like Crystal Light. We want to make sure that you don't use straws and that you don't have carbonated beverages. In addition, we're really trying to prevent dehydration, so the consumption of the liquid's important, but the timing and the frequency and the amount of liquid is also important. You want to make sure that you sip very slowly and that you drink only from the 1-ounce cups that we provide. On each tray, you'll have 4 little 1-ounce cups, and we really want you to use the 1-ounce cup. 1 ounce for every 15 minutes, not all 4 of the 1-ounce cups at one time. And this is very important to prevent nausea and any other complications. Also, any liquid should not be consumed in a large amount, especially in the beginning. We do want to aim for a total of about 48 to 64 ounces per day to prevent dehydration, but again, at a very slow amount, several times in an hour over time. Your doctor might also order you a high-protein supplement, and there are various supplements that might be recommended, and you might have one that you really like, and that will help make sure that you maintain your protein levels and heal as mentioned. Ensure High Protein is what we actually have here at Reston Hospital Center, and we also have all kinds of other products including EAS Advantage, Edge products, Isopure products, Ungery Protein, and various other whey protein types of supplements can be purchased and are usually recommended before your surgery so that when you leave you have those ready for you at home. But again, the Ensure High Protein is what we have here. Your nutrition plan will advance depending on which of the surgeries you've had and what your doctor is recommending. Some people have clear liquids for 1 to 2 days. Other people may have it for a longer period of time. Usually you're only on clear liquid while you're here after your surgery because you're headed home soon afterward. But again, your doctor will dictate how quickly that diet gets advanced. Clear liquids for 1 to 3 days, then full liquids for about 2 weeks is often the case. Some people might be on clear liquids for 1 to 2 weeks, however, and they might advance to full liquids like milks and cream soups and those kinds of things. And then also have some soft foods added or some pureed foods like mashed potatoes and applesauce and those kinds of items. Remember to follow your doctor's orders, but to take it very slowly. Even when you get to the regular food in the beginning, you want to make sure that you're not consuming too much at any one time. There are some lifelong considerations with this diet and this surgery too. One of those is vitamins and minerals. Multivitamins with iron and minerals actually need to be taken for the rest of your life. 2 multivitamins with the iron and minerals daily are recommended. We do not recommend that you use the gummy vitamins, but we recommend that you use either the liquid, chewable, or crushed vitamins. For vitamin B12, you want to have about 500 micrograms per day, and under the tongue version or sublingual is the one that's recommended. Calcium citrate with vitamin D, 500 to 600 milligrams, 2 to 3 tablets per day to give you somewhere between 1,000 to 2,000 milligrams per day is the recommended amount. As you can imagine, you want to keep your bones strong, and that definitely helps with that. You can use a soft chew, a pill, or a dissolvable version for the calcium citrate. Other vitamins may also be recommended based on your surgery and your doctor's preferences. Again, we want to remind you to eat slowly and do not drink liquids with your meals once you have regular foods. You want to have your liquids after your meals about 30 minutes afterward. And that's to prevent from feeling overfull. Protein supplements, as we mentioned, can help you get about 300 to 400 maximum calories that you need every day, but with a good amount of protein, and ensure active, high protein, EAS Advantage Edge, as we mentioned, EAS Advantage Edge soy protein also, Genesoy protein powder, Atkins Advantage shakes. I've seen people use all of these types of things. These are found in most grocery stores and or drugstores, and Walmart or online are good places to find those. Isopure Zero Carb Beverage is one of the other items people have used, and that's found at Vitamin Shop or GNC. Unjury Protein Powder is found at www.unjury.com. And there are many other protein supplements that you might find in other stores. Okay, if you want to have a protein supplement, there are some things we do recommend that you look for. Key ingredient would be the whey protein isolate. You can also use soy or egg protein. Obviously, if you're allergic to soy or egg, you do not want to use those two. But I wanted to make sure that you knew that the whey protein is a fabulous protein source. Choose products that are lactose-free and or less than 3 grams of sugar and less than 6 grams of fat per serving. You don't want to have high-fat protein supplement. That isn't what we're trying to go for after surgery. Looking for unflavored protein supplements is usually best. Sometimes it'll be unflavored or vanilla or chocolate, for example, and the unflavored mixes with many more products and juices and other items better. And protein supplements, like I had said before, should be about 300 to 400 calories total for the whole day. So you don't want to consume several of these, but you do want to remember with the limited amounts of fluid and the protein needs that you have up to the 300 to 400 calories of the protein supplements daily. Thank you.